ECG, or as I like to call, physiology in action. So in this part of the lecture, we will talk about the definition of the electrocardiography, ECG derivations, normal components of the electrocardiogram, and the ECG interpretation and electrical axis of the heart. This is the first electrocardiography recording device, as big as almost 2 persons, 2 people. So here the Wilhelm Einthoven sitting as his 2 arms and 1 leg in some kind of buckets. Why do you think he sits like this? Why do you think there are buckets? Any idea? Why did he needed buckets? He needed buckets in order to increase the electrical conductance between the body and the ECG recording machine, because the salted water increases electrical conductivity. And today we have the electrodes with the silver molecules inside, so the conductivity is quite high. But back in the 1900s, they didn't have the advanced electrodes as we have today. So ECG is a popular tool because it's inexpensive, non-invasive, and very easy to obtain. And the electrocardiogram is often used to assess the patient suspected of myocardial infarction or heart attack. And the electrocardiogram is also used as a health screening tool in patients over the age of 40 years. However, it cannot predict future heart attacks, or it cannot detect structural defects, because the electrocardiogram is the recording of electrical activity of the heart conducted through the ions in our body. So I believe you guys have watched Doktorlar in some point of your life, probably during summer, and you guys have seen this screen in many other medical drama shows. But have you ever think about why there are both positive and negative waves on the ECG? There are positive and negative waves because if depolarization wave propagates towards a positive electrode, here as you can see, this is positive electrode and this is negative electrode. And if the depolarization wave propagates through positive electrode, a positive wave occurs in the recording. But if it propagates away from positive electrode, this time we see a negative wave here. So this is for the depolarization. If the polarization wave propagates towards positive electrode, a positive wave appears, and the vice versa. If it propagates away from positive electrode, a negative wave appears. So I will ask you something, but first I will give you a hint. This is our cardiac muscle cell, and during depolarization, positively charged ions moves into the cell. But however, in repolarization, positively charged ions leaves the cell. So, what about the repolarization wave? What happens if a repolarization wave propagates towards positive electrode? Do we see a positive wave or a negative wave? Don't forget, depolarization and repolarization is opposite in molecular sense. If repolarization wave propagates towards a positive electrode, a negative wave appears here. And if repolarization wave propagates away from positive electrode, this time we see a positive wave. So there are many waves that we see in the ECG. So the sinatrial node is the part where the electrical activity of the heart originates. The impulse then rapidly spreads through the right atrium to AV node. Here, this is the AV node. And it also spreads through the atrial muscle directly from the right atrium here. The net vector of this electrical activity is shown here. So this is a depolarization wave propagates towards positive electrode. So we see a positive wave in the ECG recording. So how does the Q wave occur? The first area of the ventricular muscle to be activated is the interventricular septum, and this activates the left to right, which generates a Q wave. Here, this was P wave, and then we have a Q wave, and this is due to this net vector almost propagates away from positive electrodes. And then the electrical activity moves along the Purkinje fibers. And this causes a big net vector towards positive electrodes. And again, don't forget this is depolarization wave, so therefore we have a big positive wave, and this is called R wave. This was P wave, and this is Q wave, and this is R wave. And this is how the QRS complex is formed. Once the electrical impulses leaves the AV node, first they depolarize the septum and then ventricular walls. and this causes net vector of this electrical activity is to change rapidly. So therefore, the direction of the first part of the depolarization is towards positive electrode. So we see a positive R wave. However, the depolarization of the ventricular walls is produces a net vector that is away from the positive electrode. So therefore we see a negative wave. And then the remaining of the ventricular walls are depolarized, and this forms S wave. So we have here QRS complex, which is formed by ventricular depolarization. So what is the T wave? T wave is repolarization wave, and repolarization net vector is propagates away from positive electrode. Therefore, we see a positive T wave, because this is in repolarization, the wave occurring is opposite to repolarization. If we see a repolarization wave moving away from the positive electrode, we see a positive wave, and this generates the T wave. And we have the typical ECG appearance, starting with the P wave, Q wave, R wave, S wave, S, and then T wave. P, Q, R, S, T. And P wave is the ventricular depolarization. Atrial depolarization. QRS is the ventricular depolarization. And T wave is the ventricular repolarization. So do you think anything is missing? Come on guys, you need to contribute. Yes, atrial repolarization cannot be recorded via surface ECG recording, because the atrial repolarization happens during ventricular depolarization. Since the electrical activity of the ventricular depolarization is much more bigger than the ventricular repolarization, this causes a bigger noise, so we cannot hear the atrial repolarization. So again, P wave is the represents the depolarization of the right atria, and the second part of the P wave represents the depolarization of the left atria here. QRS complex is the ventricular, I forgot to tell, the P wave width should be less than 0.11 seconds, and its amplitude should be less than 2.5 millimeters. QRS complex is the ventricular depolarization, and there are different QRS complexes on different derivations, meaning different recordings, because the derivation means different ways to record ECG with the different placement of positive electrode. QRS width should be less than 0.12 seconds. Maximum heart rate, R wave can be seen in V4 through V6, and the deepest S wave is in V1 and V2. T wave is the ventricular repolarization. Its width should be between 0.10 to 0.25 seconds. T wave is negative in AVR and V1 derivations and normally positive in D1, D2 and V3 through V6 derivations. U wave is the last wave can be seen, but it's not usually visible. It can be due to hypokalemia, but there is no certain reason. It is mostly seen as a positive wave in V3 through V6. Here, as you can see, this is U wave. And even though there is no certain reason, the commonly accepted hypothesis is that U wave reflects the delayed repolarization of the cardiac muscle. So what are those ECG derivations D1, D2, D3 or AVR, AVL or V1 through V6? There are different ECG derivations due to the placement of the electrodes. There are two main derivations, bipolar and unipolar. Bipolar means two poles. So we use a positive and a negative electrode. And unipolar means one pole. So we record only using positive electrode. So the bipolar derivations are D1, D2 and D3. And in D1 we place negative electrode on the right arm here and the positive electrode on the left arm here. This is D1. And in D2 we place the negative electrode on the right arm again and the positive electrode on the left leg. So this is D2. And the last one here we place the negative electrode on the left arm and positive electrode on the left leg. And this is D3. And these three derivations consist of Einthoven triangle. Einthoven triangle is an imaginary formation of the three lymph leads in a triangle used in electrocardiography. And these Einthoven triangle uses two arms and left leg. The shape forms an inverted and equilateral triangle with the heart in the center. And it is named after the Wilhelm Einthoven, who theorized its existence. And we use Einthoven triangle for the basic evaluation of the electrical system of the heart. So this is D1, D2 and D3 ECG recordings. As you can see, the waveform of the ECG differs between derivations. It's due to placement of the positive electrode. Remember, here in D2 we place positive electrode on the left leg and the negative electrode on the right arm. So the main depolarization wave is towards positive electrode. Therefore, we see an higher amplitude in QRS complex in D2, and this is due to the molecular movement of the depolarization wave, and the net wave is towards positive electrode. And there are also unipolar extremity derivations. Unipolar extremity derivations named according to placement of the positive electrode. AVR means the positive electrode is placed on the right arm, AVL means it's placed on the left arm, and AVF means it's placed on the left foot. And the letter A comes from the term augmented, which means these derivations are amplified. And there are also unipolar precordial leads or precordial derivations that we place ECG recording positive electrodes on the chest. So we can look the heart from every angle possible. And there is also an optional derivation that we use sometimes in order to evaluate the back wall or posterior wall of the heart. Since the heart is placed like this in our chest, if there is anything wrong with the back wall of the heart, we have to look from the behind of the heart. So we place another 3 electrodes under the scapula in order to evaluate posterior descending arteries blood supply to heart muscle in the posterior wall of the heart. If there is something wrong with the posterior descending artery, for example, if a blood clot here doesn't allow blood flow to the back wall of the heart, the muscle cells here will begin to die. So we will see this in ECG recording. And this is all of the ECG recordings that we talked about. D1, D2, and D3 are the bipolar derivations. AVR, AVL, AVF are the unipolar derivations as V1 through V6. And the morphology of the ECG wave changes in every derivation since the placement of the positive electrode changes in every derivation. And this again gives us opportunity to evaluate the heart from the every angle that is possible. Here. These derivations, these different derivations allow us to see these different angles of the heart walls. So, in order to recap, this is the normal components of the ECG recording. The electrical activity starts from the sinatrial or SA node, and P wave is the atrial depolarization wave. QRS complex is the ventricular depolarization wave, and the T wave is the ventricular repolarization wave. And there are 12 leads or 12 derivations in ECG that we see when we get ECG recording. And these are due to placement of the unipolar and bipolar derivations. And in these derivations, we place positive electrode in different parts of the body, so we can record the heart from every angle possible. And don't forget, heart and our body is three-dimensional organ. So we need to place more cameras in order to see the electrical activity of the heart. So, if the polarization wave propagates towards positive electrode, we see a positive wave. But if it propagates away from positive wave, we see a negative wave. And if repolarization wave propagates towards positive electrode, then we see a positive wave. And if it moves if it moves away from the positive electrode, we see a negative wave. So here there are two videos. We will watch only one of them and then end the lecture. I encourage you to watch the second video. It is a long one, but